I'm Garry Nixon,
I'm Ross Lawrenson.
and both Ross and I have had pretty long sort of interest in this area, working, although in different universities, very closely over quite a number of years, probably particularly around the research side of things, isn't it, Ross? But also around the teaching.
But I think you expressed your long history of you come from a rural New Zealand background and have grown up in that and have trained in that. Whereas I came out to New Zealand in 1981 to Tikawiti and then to Waira, and have really grown into understanding the needs of our rural communities. And it's been a great journey, but it certainly left me a lot of questions about why we had to have a doctor from Surrey to fill problems in Waira, and I think we're still in that situation to some extent, Garry, aren't we?
Yeah, for sure. Yeah. And I mean, I think that's the one, that's something that we would both feel pretty passionate about, really, is that although there's been a lot of pretty good initiatives and a lot of people have tried pretty hard over the years, it's really now is the right time for something to change reasonably significantly with respect to rural health professional education in New Zealand.
Absolutely, and I think, as you say, it's the right time. I think there's been lots of really good examples from overseas that have showed actually have a stepwise leap into really investing in this area, that you can get some really good outcomes. And we have done little bits over the last 15 to 20 years, haven't we, to try and fix some of the problems. But from my point of view, in our Midland region, we still have communities where we're existing on locums, where we're really underserved for doctors, both in our rural hospitals and in our rural general practices. And it's a challenge that is a workforce challenge we really need to meet.
Yeah, and I think, both of us know that, pretty acutely, just from in terms of our personal connections with people and things like that, as well as those more formal processes around the surveys and the workforce data as well. They're still telling a pretty sad story. In fact, one which is probably getting worse is that workforce ages without really a lot of evidence that enough people are coming in at the bottom. I guess we're reasonably fortunate in New Zealand that there is so many pretty successful and different models that exist overseas. So we've got quite an opportunity to have a good critical look at all those different models and evaluate them and choose one or several or mixtures or variations of those models to find the best ones to fit the New Zealand context.
Yeah, absolutely. And I think what struck me is that there are three components to this, isn't it? It's about choosing the right students, giving them the right programs, but also looking after them in the postgraduate space.
Yeah, you're exactly right, Ross. That's what's very much accepted now, isn't it? Those three pillars, they're the things you've got to do, and also you've got to connect them as well, don't they? Because each one of those components makes a little bit of difference in itself, but the real value for money is when they're linked, and it's the students who are rural origin and have really good undergraduate experiences in rural clinical practice, and have a postgraduate pathway that's dedicated towards a rural career where you really get good results. And that's probably what we haven't achieved in New Zealand yet, is it?
No, it's not. No. So if we take each of those in turn, one of the issues for me is that we've had rural students coming from our rural schools to the Waikato Clinical School to find out about how they can get in to do medicine, and yet their success rate is really, really low, and these seem to be the brightest kids in those rural schools. So I'm not sure what it is about our rural selection that really is not allowing those kids into the program, whether it's the overlapping year one and having that program, or whether it's the concentration on high grades and the UMAT score that is dealing with that. So I don't know what your thoughts are about how we change the selection criteria or the way into medicine.
There's some and I got raised a little bit in the discussion around there. There's some pretty interesting stuff occurs overseas with respect to that rural origin sub-quota and how it's managed. And there's some really nice examples, isn't there, whereby for some universities that rural origin stuff is done at the individual community level, where actually members of that community have some responsibility when it comes to selecting a small cohort of medical students who are then tied to that community to a certain extent right through their training. So if they're selected in that way, then they know that they'll be returning to that community for a full immersion year, as well as perhaps for a couple of weeks each year in other years. And then there's tends to be in that situation quite a strong sense of ownership, in both directions between the student and that relevant community. So I think there's good ways of that.
And much more effective than a bonding system, which I'm not sure you think about bonding, but I'm not keen on compulsion at all. In all honesty, I think it's been shown to be pretty unsuccessful.
That's right. And it can be almost slightly harmful if you've got students and that in a community and they don't want to be there. That's pretty disheartening and discouraging for the teachers as well too. I don't think it works very well in either direction. Bonding. I tend to agree with that.
And what about the training program that we have at the moment, and how we can improve that for students who want to go rural and stay in rural communities?
So you're talking about the post-vocational training now?
No, I'm talking about the medical training.
That next step,
you have the RMIP program in Otago, and that seems to be working, but only for a small number of students who get the opportunity to do that. It's expensive to do, isn't it? Or so we're told.
Yeah, we are, and we are told that it is quite. We are told we're going to say. I mean, you're exactly right. I mean, numbers are small. I mean, in Australia, then it's pretty much standard 25% of the medical class, and our RMIP is way below that 25% mark. In all honesty, I think one of the reasons why it's so expensive is because there's not that coordinated infrastructure in the rural areas. And each of those programs is trying to operate pretty separately and pretty individually in each of those rural communities. And I think there would be, get quite a lot of value for money by increasing the number of those RMIP students. And at the community level, tying their education in with the postgraduate, with the research, with the rotation students as well, which then you come down to this other, what I consider to be pretty significant problem in terms of lack of academic capacity in rural areas.
That's the big block, isn't it? Is actually where do we get our teachers from, and how do we support them to have the time to look after students and meet the clinical demands and everything else that are going on.
And we just haven't done that like they've managed to do in Australia and Canada, for example, do we? We just don't have those rural academic positions out there.
That's good. I don't think we've put them up as a priority, and I know that we're paying a fortune for locums in some of our rural areas, and particularly in our rural hospitals. Whereas we could actually put up a job for an academic who's going to look after registrars. And that, to my mind, would actually really invest in that community, invest in training, and invest in the long term, rather than putting the money into locums.
I agree completely. I think that would be seriously a very good investment. And not only in terms of training that next generation, but also in very much of being part of and supporting those who are currently in practice. Very important.
So the other thing you've done really well is the Rural Hospital Medicine Training Program. But I just wonder about your comments about the gap between qualifying and those 2 years of postgraduate training, and how you then recruit people into the Rural Hospital Medicine Training Program. Do people get lost in that 2 years, and do they find that there are barriers to them coming into the rural hospital training?
They do. They do get lost. I mean, it's a pretty leaky pipeline. And the longer that someone is away from any contact with rural communities and rural medicine, then they're much more likely, exactly right, to lose them. I mean, if they've got 2 or 3 years of solid hospital-based urban medicine, then it's not surprising that then that's what determines their long-term career. So I agree completely. Sort of putting in something in those years is really, really important as well too.
Somebody who was a house surgeon at Tikawiti Hospital, where we had a whole bevy of house surgeons, doing their roles down there. There's, I think, an opportunity to actually take some of those PGY1s and put them in different settings. So that, as you say, they don't get lost to the system.
That's right. And they'd be excellent, training and learning opportunities for those PGYs as well. Very much so. A lot of hands-on clinical
and
practice.
The other thing you've done is build an academic component into the Rural Hospital Medicine training program, and research and having an academic base for our specialty of rural medicine is really key, isn't it?
It is. I agree completely.
Building that is a challenge.
I mean, those things are accepted as standard and normal within other branches of medicine, and we're not asking for anything more when it comes to that, are we? We're just saying we just want to have the same access to those things in this particular area of medicine as all our specialist colleagues and our urban general practice colleagues expect as being normal.
So if you're appointed as an academic, 40% of your time should be research.
It should be. It should be. I agree completely. And that service component's a very important component, particularly when you're in rural as well too.
So how are we going to get a solution for this for the whole country? That's going to be the challenge, isn't it?
We got two quite good solutions that would sit together quite nicely, wouldn't they?
Absolutely. We should get them to fund both. That would be the way forward. Anyway, Gary, it's been great talking to you.
And I'm sure we'll do lots more of it.
Good.